These are my disclosures. I've had the pleasure of working for most of the companies that have anything to do with diabetes. And as mentioned, tonight's program is sponsored by AstraZeneca, who is kind enough to provide some of the logistical backing in the form of an educational grant. And as mentioned, as always, we'll try to present as much guidelines and published material. Any of the opinions you hear this evening don't reflect those of AstraZeneca or LMC. Here's the learning objectives. As mentioned, heart failure, obviously one of those forgotten complications of diabetes. We'll try to raise some awareness, some of which you're already aware of, but hopefully from the perspectives of the cardiologist as well. We get lots of landmark trials in endocrinology. Now we're moving to dedicated renal and heart failure trials that also have a bit of a twist with diabetes. And as mentioned, as a lot of us have already come to see, a tremendous overlap between the cardiovascular and renal benefits, predominantly with the SGLT2 inhibitor class. And then as part of the reflection period of this, there'll be a follow-up survey that we'll share with you at the end of the program, more details that I'll share at the very end. So I'm not sure that this is necessarily going to be the order that we go into this evening just because of some technical challenges. I'll ask one of my co-hosts if she is available. Eileen, have we managed to fix your audio, or shall we start with Dr. Schlosser? Sound of silence obviously tells me what I need to hear. So for tonight's program, instead of starting with a heart failure update, we'll actually start by making sense of the new data. And so with that, I'll introduce Dr. Schlosser and stop sharing my screen. We'll allow Rob to do so. Rob is a well-known figure with LMC. I think you were like one of the founding members of LMC, if I'm not mistaken, with Dr. Aronson 2 or 3 years ago, if I'm not, for something like that, or 20 years ago. Dr. Schlosser completed his endocrine fellowship at the University of Western Ontario, certified in endocrinology and metabolism by the Royal College of Physicians and the American Board of Internal Medicine since 1992. I wasn't very old in 1992. Presently, Dr. Schlosser is a staff endocrinologist at Mackenzie Health Hospital in Richmond Hill, also the medical director of the Diabetes Education Center there. Has been with LMC for a couple decades, and tonight he'll try to make sense of some of this new data. Rob?
Thanks, Alex. So just to confirm, you can see my screen? Perfect. So we're going to start with part 2, which is the data part of it, and from an endocrinology point of view, it's really exciting to see all this data. We've seen most of it. Presenting it and distilling it for the family docs is the challenge for us and the community going forward. So these are my disclosures, similarly to all the other speakers. Any company that has anything to do with diabetes, mostly I've worked with. So just as a framework, unlike microvascular complications and to a lesser extent macrovascular ischemic complications, heart failure has really not been demonstrated to be modifiable by better glycemic control. So if you look at the standard glycemic control trials in early and advanced diabetes, there's really no evidence that heart failure outcomes are affected by overall better glycemic control in these older trials. And if you look at various trials of anti-hyperglycemic agents, although none of these are primary outcome heart failure trials, but they had, in all these outcome trials, heart failure was well characterized and measured. Really none of them, of all of the classes of agents shown, have shown a difference in favor of study drug versus comparator to reduce the risk of hospitalizations for heart failure. Some, as you know, have shown detrimental effects, saxagliptin in the SAVOR trial, the 2 TZDs specifically, but really nothing short of the SGLT2 inhibitors has shown benefit. So the case that we're going to present is Alice, who's 74 years old, has had diabetes for some time, 15 years, had an MI, as well as diagnosed with heart failure with a reduced ejection fraction 2 years ago. She's very well treated, we would all say. She's on metformin and semaglutide for the diabetes, rosuvastatin for her lipids, ACE inhibitor, indapamide, spironolactone, furosemide, bisoprolol, ASA for heart failure and blood pressure and CV risk, etc. So she's on multiple meds. as you can see. So you can imagine this patient may have some pushback if you suggest another one, especially given her control. So being well treated, she actually is at a reasonable target for A1C, 6.7%. Her lipids are excellent. She has some evidence of CKD, stage 3A, and has some albuminuria as well. Her blood pressure is well controlled, her BMI is 27, and she's in to see us for a regular follow-up. She's been doing well with her current regimen and feeling well with no specific concerns. So we're going to launch into a poll and ask the audience, not all of these are mutually exclusive, obviously, but what would be your next step for a patient such as Alice? Order an echo and or BNP, refer to your local cardiologist, add an SGLT2 inhibitor, keeping in mind that her A1C is 6.7, add and adjust one or more of her diuretics. Recall she's on 3 diuretics, otherwise indapamide, furosemide, and spironolactone, or nothing and just continue to follow her on her current regimen. We'll give a little time for the audience to answer.
There's still some movement in the poll question, so we'll give everybody another 10 seconds or so, and then we'll share the results. Give a distribution. We have about half, so I'll end the poll and share the results. Oh, actually, a couple more coming in. All right, I think everybody.
Mail-in votes have to take a little longer.
Yeah, that's right. Varsha will have to tabulate those and share those afterwards, especially Stuart's that's coming from Vancouver. All right, so here are the results. Rob?
Yeah, so there is the most popular answer is the fourth one, adding an SGLT2 inhibitor and adjusting one or more of her 3 background diuretics. I guess we should discuss subsequently which one of those 3 or more one would adjust. But all of us are obviously very comfortable with using an SGLT2 inhibitor, recognizing that her blood pressure is quite good, and I suppose the worry is that adding yet another diuretic, so-called diuretic, may negatively affect her blood pressure and cause hypotension. I suspect that's the reason. So that's a reasonable approach, and we'll see if that changes as we go. So moving forward. Let me just get back to my slides. So this is a tool that some of you may be familiar with, but I find this very useful. This is the TIMI risk score for heart failure. This is really a nice piece of science from the outcome trials. So the TIMI group, of course, ran both the SAVOR TIMI trial with saxagliptin versus placebo and the DECLARE-TIMI trial with dapagliflozin versus placebo. And what they did was, looking at heart failure, develop a risk score to predict risk of hospitalization for heart failure in those populations. So they used the SAVOR placebo group as the derivation cohort, so the baseline in terms of risk. And they found that on a 7-point scale, you could fairly well predict risk of hospitalization for heart failure. And the 7-point scale shown on the left, 3 risks are cardiac, prior heart failure, obviously, worth 2 points, atrial fib, 1 point, coronary disease, 1 point. And then the other 2 are renal, GFR under 60 being 1 point, and macroalbuminuria 2 points, or microalbuminuria 1 point. You obviously can't have both. So that's why it's 7 out of 7, not 8, because you either have macro or microalbuminuria or no albuminuria. A high score is considered 2, 3 or higher is very high. And you can see in the TIMI group, there's a nice gradation of risk for hospitalization for heart failure. And then they went to the placebo group in the DECLARE trial, having derived this risk score from SAVOR and validated it, and showed similar distribution of results in a somewhat lower risk population, but nevertheless clearly validates this as a really easy to use, I think, clinical risk score that can be used in other trials as well as in regular practice. And we'll come back to this in terms of therapy in a moment. We're all familiar with the cardiovascular outcome trials, the MACE outcome trials in patients with type 2 diabetes regarding SGLT2 inhibitors. There are now 4 that have been published: EMPA, CANA, DAPA, ER2. You can see the characteristics. Obviously, these trials are different from each other. They are often compared. and you can argue the validity of meta-analyzing them. They are similar but different in terms of patient population, how large the trials are, how long the trials ran. The primary outcomes are the same, other than DECLARE had a co-primary outcome including cardiovascular death and heart failure. So DECLARE really is the only one that had heart failure as part of a primary outcome. Multiple secondary outcomes that overlap with slight differences in the definition of renal outcomes, and the follow-up as shown there. But nevertheless, these are all the FDA-mandated safety trials which subsequently have been published for SGLT2 inhibitors versus placebo in MACE outcomes. As we all know, about 5 years ago, I guess it's the fifth anniversary, this EASD meeting of EMPA-REG outcome, landmark trial, showing reduction in MACE, mostly driven, in fact, exclusively driven by cardiovascular death. But we're going to focus not on the MACE outcome, but on heart failure, since that's the topic of the day. Heart failure was a secondary outcome. It was not part of a hierarchy, so it's exploratory, but nevertheless, it was clearly beneficial in terms of, in favor of empagliflozin versus placebo, a 35% reduction in hospitalization for heart failure, which surprised many people. A lot of cardiologists and people focus on the left lower part of the Kaplan-Meier curve, where there was clear early separation in the first few weeks in favor of the drug. Which is really not seen in any other intervention in heart failure, to my understanding. So this was somewhat surprising, both in degree and rapidity of the response. But it turned out to be true. If you look at subsequent trials, Canvas, again, a secondary outcome, not part of the primary outcome, therefore exploratory, as it was not part of the hierarchy. So it's a nominal p-value. Nevertheless, similar hazard ratio of 33% reduction in hospitalization for heart failure in favor of treatment, canagliflozin in this case, versus placebo in a similar group, although slightly lower risk because there were some risk factor patients there. And along comes dapagliflozin, an even lower risk group, because only 40% of the patients in the trial had established heart disease. In the composite of CV death and hospitalization for heart failure, which was a co-primary outcome along with MACE, that rendered it a positive trial, p.005 for superiority, 17% reduction in the composite of CV death and heart failure in favor of the drug. And then breaking down the co-primary outcome that was positive, really driven by hospitalization for heart failure, the hazard ratio being 0.73 or 27% reduction in favor of DAPA. No difference in this trial in terms of cardiovascular death, but a much lower risk population. And if you go back to the TIMI risk score that I showed you and apply it, in this case, not to just looking at placebo and deriving the risk, but to treatment effects, it was done very nicely, and it demonstrated very nicely that patients with the highest risk of hospitalization for heart failure in the TIMI, by virtue of the TIMI risk score, had the greatest absolute benefit. The hazard ratios are actually the same, rather in low risk patients all the way to very high risk patients. You can see ranging from 0.66 to 0.75. They overlap and are not really different from each other. But what's clearly different is the absolute risk reduction. In the very high group, 2.7%, less in the high risk, 1.5, and so on, less in the lower risk groups as expected. And that renders the number needed to treat, obviously, much, much lower if you're treating the patient population with a very high risk. So although this is not a heart failure trial per se, it was designed as a MACE trial, there's a clear heart failure outcome benefit, and it does tend to skew, especially in absolute risk reduction for patients who are shown to be at high risk by the TIMI risk score. This is a further sub-analysis of DECLARE, looking at who were these patients who benefited from with respect to hospitalization for heart failure. And again, caution here, this is not a heart failure trial, so these patients were not characterized as they would be in a primary heart failure trial in terms of ejection fraction and followed in that way. This is by history, whether they had HFrEF versus not HFrEF, and some of those not HFrEF patients had HFpEF, preserved ejection fraction, and some had no history at all of heart failure. But if you take out specifically focusing on the HFrEF population, not only the primary outcome is driven by that group, as is hospitalization for heart failure, but you can see a mortality benefit where you don't see it in the entire trial, obviously hypothesis generating. But if you're looking for a mortality benefit within the DECLARE trial, there may be one in the pre-existing HFrEF population, which was subsequently shown, as we'll show you in the DAPA HF trial, to be a primary outcome in favor of the drug. For completeness, I show the VERTUS trial. As many of you know, the ertugliflozin, the fourth SGLT2 inhibitor MACE trial versus placebo, was negative for MACE. There was numerically less MACE events, but it did not reach statistical significance. So the trial was really negative. But they did look at heart failure, and despite that, again, exploratory, obviously, similar hazard ratio of 30% reduction for hospitalization for heart failure. Again, fairly early separation of the curves in favor of the SGLT2 inhibitor. Now, those are MACE trials. Looking at the dedicated heart failure trial, there's now 2 published in the literature. There's DAPA HF, and very recently EMPEROR-Reduced, published, similar but somewhat different. Looking at heart failure patients with reduced ejection fraction. High BNP criteria in both trials was slightly different, but they all had to have some degree of elevated pro-BNP. Both trials included diabetics and people without diabetes. The primary outcomes slightly different because DAPA HF included urgent heart failure visits, so heart failure that was bad enough to visit an outpatient clinic. But the other trial, the EMPEROR, was just heart hospitalization and CV death. Nevertheless, I don't think that really makes a difference in terms of the outcomes because both trials were positive. The secondary outcomes tested in the hierarchy are different. DAPA HF, CV death or heart failure, which was the same primary outcome as EMPEROR. Total heart failure, meaning the first and recurrent events, because all the primary outcomes are time to first. This secondary outcome is total heart failure and CV death. Change in Kansas City score, renal outcome, and time to mortality. The first 3 secondary outcomes met the hierarchy. The renal outcome did not because of lack of power, although mortality actually was reduced, but it was exploratory. In EMPEROR-Reduced, the first 2 outcomes, first and recurrent heart failure, so total heart failure and eGFR slope from baseline as their renal outcome, did meet the hierarchy, but after that, everything else was exploratory. The rationale was they want to try to preserve some alpha for a meta-analysis that will be combining EMPEROR-Reduced and EMPEROR-Preserved so that they can meta-analyze the 2 and still have a statistical significance. So the others are exploratory by design. But nevertheless, here are the results of the 2 heart failure trials. Both were positive for primary outcome. In the case of DAPA HF, worsening heart failure, meaning hospitalization or clinic visit or CV death, by 26%. Breaking that down in components, 30% reduction in heart failure, hospitalization, 18% in CV death. Not tested for significance, but the hazard ratio did not cross the line of unity, so they were both below the 95th percentage confidence interval in favor of the drug. Secondary outcomes, again, positive for heart failure outcomes for the trial, no matter how you define it. And here's the Kaplan-Meier curves for hospitalization for heart failure. Again, early separation in a dedicated primary outcome heart failure trial, 30% reduction in the primary outcome. And looking at the breakdown between patients who had diabetes versus did not. So 55% of the patients did not have diabetes at the baseline, and nevertheless, there really doesn't seem to be any heterogeneity. So if we need more evidence that glucose lowering does not appear to be mediating the heart failure benefit, here it is. They didn't have to have diabetes. There's further analysis of those patients who had pre-diabetes versus normal glycemia, still no difference. So really it doesn't distribute at all depending on glycemic status. The drug seems to work in a different way. EMPEROR-Reduced, published more recently, again, similar primary outcome, relative risk reduction of 25%. A little bit different in the distribution. It was mostly driven by heart failure hospitalizations, 31% risk reduction. CV death was 8% in favor, did cross the line of unity, so that was would not be statistically significant if you go by 95% confidence intervals. Secondary outcomes, again, in favor of the drug for total heart failure, and the renal outcome as they define it, which is the slope of the decline in GFR, but not a renal study. So these patients did not have severe CKD. Looking at the Kaplan-Meier curves, again, similar pattern as with all the heart failure Kaplan-Meier curves in favor of the drug. And again, similar, no real difference whether patients had diabetes or did not have diabetes. This does not seem to be glucose mediated. And finally, this is sort of a modeling slide. So this was presented recently, and looking at not only SGLT2 inhibitors, but what would be called disease-modifying therapies. So looking beyond conventional therapy for heart failure, which includes a beta blocker and a RAS inhibitor, keeping the beta blocker, but moving away from the RAS inhibitor to an ARNI plus an MRA plus an SGLT2 inhibitor, so-called modern therapy based on evidence-based, based on trials with evidence-based medicine. If you combine all of those things, again, this is not a trial, this is a model, but what's the expectation you can see in terms of outcome reduction in favor of the comprehensive rather than the conventional approach, and the numbers are quite staggering. Obviously, needs to be confirmed in a prospective trial, but really large impact on all outcomes, including mortality as well as hospital admissions. That's my final slide. So with that, I'll leave it to Alex to either give it to Eileen or Stuart. And I'll stop sharing.
Thanks, Rob. Great presentation. I think everybody should be able to hear me again. Let's do another test. Eileen, do you have phone audio? No? All right, still working out some of the technical glitches, but we assure you we'll have it worked out in time for the third presentation. Stuart, that means you'll take over next, so we'll allow you to take control of the screen share and start section 3 in our slightly out of order presentation this evening. We'll obviously have lots of time for questions. If anybody has any burning questions that they don't want to forget, the chat box is available. You can type in your questions either for Dr. Schlosser or any of our speakers. For now, we'll give you part 3 of translating evidence into clinical practice with Dr. Stuart Ross. A very brief bio for Dr. Ross because they get lengthy. For over 40 years, Dr. Ross has been a leader in clinical care, education, and research in endocrinology and diabetes medicine in Canada. He studied medicine at Otago University in New Zealand, where he received certifications by the Royal College of Physicians of Canada, as well as the Royal Australian College of Physicians. Dr. Stuart Ross has served as clinical professor of medicine at the University of Calgary since 1985 and also works at the LMC Diabetes and Endocrinology in Calgary. He's contributed to over 150 textbooks, abstracts, and publications. I give you Dr. Stuart Ross.
Thanks, Alex. Nice to say hello. And just to disillusion you, I'm not in the great metropolis of Vancouver, but in the tiny metropolis of a little town called Sicamous, right at the top of the Okanagan Valley. And remote and great for self-isolating. I can recommend it. Lots of lakes and sunshine. Well, apart from that, so we're going to take another sort of little dive in a different direction. The concept translating evidence into clinical practice is one which I think all of us are dealing with on a daily basis. I must tell you that I'm not entirely orthodox in the way I approach clinical care, because one of the things that has always struck me is the concept of individuality of patients. So when somebody says, but the trial didn't do it that way, or the guideline didn't tell me that way, I nod wisely and agree, but sometimes the patient presentation dictates a certain way to proceed. Just trying to see if I can get the slide to change. There we go. Just to present disclosures, I have worked extensively with multiple companies for teaching and doing research, and these are the patients, these are the ones that I am working with. I wanted just to show you the slide of Dr. Verma, which I've always liked, it kind of talks about this concept of spectrum of diabetes. Instead of us looking at one thing, a microvascular or a macrovascular or a renal or whatever, it talks about the concept that diabetes affects multiple parts of the system and they overlap. So we've always been aware that if one of these parameters is present, the others are probably either there already or not far behind. But it's very interesting over the decades that I've had the opportunity to work with diabetes is how this concept was not popular. It was very glucocentric, and if you control glucose, then you just got it right. But all of you can remember the wonderful trials that took place 20 years ago now, over 20 years ago, where beautifully controlled trials looking at glucose control, but no cardiovascular benefit. And there's a lot of disappointment and a lot of negativism related to that because people said, well, treating diabetes isn't worth it because they're going to die anyway. So now we're taking a totally different phase to this. We're looking at this now as a comprehensive problem and where we overlap with not only in terms of identifying something, but also in managing where we're heading to. This is another concept that most of us are very much aware of. It's interesting, again, without being too derogatory to some of our wonderful colleagues in cardiology and nephrology, how they formed silos. I guess we all do that. And the wonderful thing about the clinical trials that have taken place in the last few years has been the breaking down of barriers of understanding the common linkages and the common ways that we need for treatment. And I know that Eileen will have a lot more to tell us about that in just a few moments. But the issue is simple. In the presence of heart failure, there are changes which will lead to kidney damage, and that kidney damage will lead to changes which will accentuate heart failure. So we talk about a cardiorenal syndrome, but it is bidirectional. It's going in both directions. And therefore, when we treat, we have to think of both. So when therapies come forward, which says you might be able to treat both at the same time, that is a quantum shift because we just didn't have that in terms of managing diabetes until very recently. If we look at this sort of ladder formation, we can see that, in fact, the SGLT2 inhibitor is acting in two major sectors, definitely in terms of glucose, and we know that we've seen glucose lowering. We know that there's increased inflammation. There is many benefits in terms of, and weight loss, all those things are there from the SGLT2. And that, of course, was the original way that most of us, when we did the clinic, that's what we were looking at. And we're very pleased with the results. But the other side, which has now come to the fore, is this whole concept of renal and cardiac benefit. And that, of course, has led to many other concepts of how we should be managing. In this presentation, I will repeat some of Rob's slides, not to go over them again, but just to allow you to remember some of the very important things that he's just shared with us in terms of those clinical trials, some of which, of course, have just been released within weeks. So let's just start off with some general discussion points. One of the things that all of us asked quite quickly when we began to see the improvement in renal and potentially cardiac situations was, what about the non-diabetic? And as endocrinologists, you can say, well, that doesn't affect us, but of course it does, because who hasn't seen a thyroid patient who turns up with significant renal disease, and we're saying, well, we better get the nephrologist involved. But now comes the question, would the SGLT2 be important in those patients? And I will discuss that further. And I wanted to just bring this up briefly because it has been a question asked to me many times in the last months about type 1. And so the issue, as Rob has described to us, is the very broad range of abnormality that those trial patients exhibited to be part of a trial. So we know that the effects on renal, effect on heart, effect on glucose appears to be universal. It does not appear to be selected. And so the question was, why would it not work in a type 1 patient? There are the sort of the pushback a little bit. Some of you will remember the big controversies with ACE inhibitors in type 1, where some said, well, you know, type 1 is going to get renal disease. It doesn't matter if they haven't got it yet, put them on an ACE. But that never showed benefit. But when they showed abnormality, like proteinuria, then an ACE was very beneficial. And it probably is very much the same with the type 1s and SGLT2. The more important question is your comfort of actually using them. There's a big divide amongst all of our colleagues on this one. And I bet across LMC, it'll be interesting to do a poll one day, how many would consider using it in a type 1 patient for glucose control, and how many would not because of the DKA story. Whatever your preference, the chances are that there is benefit for the type 1, particularly in a patient who has heart failure or significant renal disease. There are now, if you look at some of the data, especially from Europe, where they have been using it now for some years, they've built beautiful clinical management algorithms that enables the type 1 to use the drug with a lot of safety. I'm not sure that will happen in Canada, but there is no question that there would be benefit in the patient with heart failure and probable renal disease based on those broad trials that we've already seen. If we take a look at a patient, same sort of issue that Rob was talking about. This is a gentleman, 74. He's had diabetes for 12 years. He's an atrial fib, no history of cardiovascular disease or heart failure. He is on a pretty good medical regimen. I don't think any of us would disagree with all those things that he is on. If we look at his lab situation, he's well controlled, low LDL, some renal impairment, blood pressure is good, and he is certainly not overweight. I wonder if he's even a Canadian. We'd have better check on that, Alex. Pretty unusual to see 23 kilogram amongst Canadians. But the issue is that he's lost his appetite and he's been losing weight. So there may be a reason for his lower BMI. So a series of questions that I'd like to put to you and pass that back to Alex. But as the sort of questions we'd have to think about, would you do a clinical assessment for CHF? Would you order cardiac or lab work that might prove it? What about the role of the cardiologist? Should we automatically add an SGLT2, etc.? The others are all there for you to see. And why don't you give us your opinions?
It's a tough question, Stuart, for sure. And I can tell you that we're getting some responses coming in slowly, so we'll give it some thought. The whole idea, I guess, of, challenging the whole concept of the physical exam that we all learned months ago versus just imaging versus just starting therapy, as, whether or not it changes management. It's a bit more of a distribution here. We'll give another 15 or 20 seconds just to see if more answers come in. Everybody's eating dinner, it looks like, so slower on the responses.
It's iced tea time out here with the sunshine.
That's right. All right, well, again, we have the majority of the answers. If anybody else wants to answer, we'll give you another second. All right, so we'll end that. This one might be a bit harder to speak to, Stuart, so we'll end the poll. We will share the results with everybody. Your thoughts, Stuart? Are you surprised?
No, I personally would want to do a very thorough clinical setting. I don't know why he's losing weight. He doesn't exhibit any obvious symptoms, but I do know that he could well be in CHF. He's got the reasons to have it. So I would do that. The tough part is where to go to from there. Yes, to order an echo or to order lab work. We have in Calgary, we can get the BNP done as a routine, not a problem. And that often is very helpful. Refer to a cardiologist, great idea. It might be a 6 or 9 month wait. If I even want to get an echocardiogram in the COVID era, it might be somewhere in 2021, 2022. So if I detect clinical signs of CHF and I can get the BNP done and it confirms what I'm looking for, or with X-ray, then I would certainly be looking towards an SGLT2. It's interesting, I actually threw the question towards a cardiologist in a meeting we had actually prior to COVID. And I asked them, you know, when we suspect heart failure, what do you want us to do? The cardiologist said, well, you should send them to us. And I said, well, how long will it take you to see them? And you've got to remember how many we might be seeing. So we kind of ground down to, well, you could proceed if you wanted to. I think the SGLT2 provides me with a totally different way to approach this problem. And I would be very tempted after my good clinical assessment, see what tests I could get done quickly to be considering it. And Alex, we might be able to get some more feedback on that, because it's not one of those easy answers, because there are various different ways in different settings. You might have wonderful service in Ontario and Quebec where you can get everything done by the next day, but that's not always the case. Okay.
And continuing on that thought, if anybody does have any other points to share, provincial or otherwise, there's always the chat, and you know, Stuart and I or the rest of the committee can obviously come to it later on.
We'd love to do that, because as I sort of started off with my presentation, there is no gospel here. This is where this concept of not only individuality of patient, but what services are easily available and convenient and will provide the most information. I think that's these are very important clinical areas to try and resolve. Okay, we'll probably come back to that, I would think, one way or the other. Just trying to get rid of this. Sorry.
I think you just click back on the slide. Yeah.
Yeah, just trying to get, there we go, we got it. Okay, so MACE, well, obviously the results, this was the original data we saw way back, as you mentioned, 5 years ago, which totally blew us away, that we were seeing benefits in MACE with the very earliest trials on the SGLT2. And it's sort of been a little bit of a mixed bag, where some do and some don't, and some patients will and some patients won't. And I think again, it's a question of trying to look at this based on what is happening to the patient and what things might influence it. Again, some of these are a little bit of a repeat from Rob. Many of you will have read the Zellnicker articles. Some controversy over the articles because it appeared to be more like a meta-analysis of multiple clinical trials. And many of us have a problem with that. Even when we look at these various trials, there are similarities, but as Rob just pointed out, they're not all the same, and not always the same patient inclusion and the length of the trials. The endpoints are not always the same, the doses are not always the same. In some studies, they were using full dose SGLT2, in some they were not. So always keep that in mind, that we really should not directly compare one trial to another. That's particularly important, as you'll often hear someone says, well, which is the best one? And the fact is, unless they do head-to-head trials, we're never quite going to know that. But we can look at the data and say, this particular trial achieved this, so I know what I'm going to get if I prescribe that particular drug. And that's, again, being selective and individual in terms of both drug therapy and patient. But regardless of that, he did provide a look at it in a very different way. And what you can see straight off is that in this situation, there was questions, you know, we remember Health Canada didn't want us to even use these drugs with an EGFR less than 60, and now that number is dropping. And we know that the trials at least went down to an EGFR of 30, but in many of the trials, they were even lower than that, showing benefit. So it appears that if you look at the combined data, again, it's effectively a meta-analysis, that line lies basically to the left, particularly in patients with impaired or lower EGFR. Not so clear in patients who have normal EGFR. So I think this helps us as we see the various patients in front of us, and I'm thinking about, would I want to use a particular drug to get a particular outcome? I do have the confidence that that EGFR will be a guiding point. So this is quite an interesting analysis. If we look at heart failure, he did the same again, this time much more clearly showing that if you have atherosclerotic cardiovascular disease, the results are pretty outstanding no matter which of the trials that we look at, but not quite so clear in patients with multiple risk factors. Again, you've sort of got to be careful about the number of people being treated, how many did or did not have certain types of risk factors. The point really is, though, that if you look at the line of unity, it generally lies to the left. And yes, the confidence limits are crossed in some of the individual trials. But again, it would say to me, I'm not going to do harm here, and I could be doing a lot of good in my individual patients. So again, confidence with the drug class and what we can see with it. What about this important question, what if they don't have heart failure, and should we do that? Well, the interesting thing is that the results, again, were very positive in those with or without heart failure in terms of heart failure and cardiovascular death. And you can see here the results from 3 of the very big trials. These are beautifully designed trials, well conducted. We're well away now from the rather skimpy type of cardiac outcome trials that took place 20 or 30 years ago. But again, the confidence is shown in all these trials with DECLARE and EMPA, and even really in Canvas, showing that these drugs will be beneficial in terms of preventing it. The question, is there a role for the endocrinologist? Well, depends. If you talk to some of our cardiology colleagues, they say, no, we should be doing that. But of course, we're reversing the thing, saying, well, as a cardiologist, you should be doing some of the treatment as well, using diabetes-related drugs. And that's causing an interesting and, I think, very beneficial discussion between the 2 disciplines. So is there a role for the endocrinologist now in this setting? Absolutely. Probably even more so, because we may be some of the first to detect that there is a risk situation, and we may want to include it. So we're now talking not only of treatment of disorder, we're talking of prevention, and that is exciting in itself, okay? Rob, I'm not going to go into any more detail because he's so beautifully described these 2 trials, but these are just out in the last weeks and month, really showing us data that is quite astonishing. If you look at the results with the DAPA HF versus the EMPEROR, he described those 2 trials to us. This just analyzes or shows in a table format how both of them showed positive primary outcome, but not everything else came out positive. But the real big thing in both these trials, look at that, 41.8% in DAPA and nearly 50% in EMPEROR did or did not have they had diabetes. In other words, the majority did not. So this is really changing the way we have to think. Agreed, we may not see quite so many of these people because we're more likely to see the diabetic patient, but we do a lot of clinical care outside of diabetes, and this now raises this very important question. Maybe these drugs are going to be more important. And I'm really interested in what Eileen has to say about this, she being the expert on heart failure, as to whether the heart failure experts, the cardiologists, are going to start saying, wait a minute, we've got drugs which might be very effective in managing even if you do not have diabetes. So a fascinating set of questions coming from this. And Alex, maybe we might invoke some chat as to how people feel about it. It's a big step for us to make that jump. But now we're starting to talk about a very different group of patients who could well benefit. If we talk about renal disease, if we look at the various trials, there is no question. Look at that data. When as we have done now, linked in the last years so closely with our renal colleagues, they're ecstatic. And I would agree with them because, again, I've lived through the phase where there's nothing you can do. You do your best, add a bit of this and a bit of that, watch the blood pressure, etc., but they're still deteriorated. And now we're looking at major changes in all these different trials. And of course, Credence and now the DAPA trials are all showing this benefit. This is Credence. Again, it was just a thrill to see these data being published and released. Data that when you start to analyze how long the benefits are occurring and the benefit to the individual patient, it is huge. And so we are entering a totally new era in terms of prevention of death and progression of disease. Same data came out of the DAPA CKD trials, beautiful data showing very similar and very effective results, both of course in renal and in heart failure. So we have another drug, and this is just looking at the various trials, just reiterating how they are a little different in terms of how what they're looking for and who came into it. But again, look at that bottom line in the yellow, with DAPA and EMPEROR showing, and also the DAPA CKD, showing that it was not entirely a diabetes population, and yet there was benefit right across the system. I must comment because I've been involved with clinical trialing for many decades and have written many big trials. You have to be very brave to do this. You have to have confidence that your medication that you're testing is going to have some benefit, because the costs of a clinical trial are very high and it could really fall flat. So I'm impressed that these companies took the challenge and shown us brilliant data. If we look at the, again, this is just looking at the various trials. Again, it's really a summary slide of what Rob has shown us. But again, it just emphasizes that there are differences between the trials, but, and of course the numbers of diabetics who are in the trial, but we are able to do comparisons. As long as we're careful not to directly compare one trial against another, we can interpret the information by saying, this is what they looked at, this is what they showed, this is the type of drug I'll need to use for my specific patient. So what do we make of these new data? How do we simplify and translate these benefits and new data for our primary care colleagues? This is such an important question. In Calgary, our group and LMC provide an extensive service of phone consultation to physicians and all educators. We have a big pharmacy group who do education across the province. And also in Western Saskatchewan and Eastern British Columbia, to call in with questions about their patients to save sending them into us, sometimes a long and dangerous drive, especially in winter. And they are full of fabulous questions, but they're confused. What do I do now? Should I use these in this situation or that situation? And I would welcome commentary about that. I tend to be, shall I use the word aggressive with my management, because I see benefit in these new drugs. I think the new SGLT2 trials and GLP-1 trials have opened our eyes to new ways of doing things. It is fascinating. I don't know if many of you picked up the broadcast on the EASD this morning, where they're outlining new guidelines for renal impairment. And the person doing the presentation recommended first-line therapy of metformin and an SGLT2 in a patient with renal impairment. That's, I'm assuming, with diabetes. Will we go that route? Well, our new guidelines didn't quite do that. And I like the second question, Alex, because the recommendations are out, and I think people have to come to their own conclusions about that. There is some confusion, I think, from them. And also, of course, I do realize how impossible it is to stay up with every trial, but they did miss the big DAPA trial and EMPEROR because they were published just so recently. And they do have an influence on terms of clinical practice guidelines. So I think if we always accept that guidelines are guidelines, it allows us still to take new data and be able to proceed. But again, I'd love to hear further conversation and discussion. In terms of what we can learn clinically, we have to recognize the high prevalence of CHF in type 2 and its morbidity and mortality. As endocrinologists, we've kind of thrown it towards the cardiologist. You look after it, but they often have not been diagnosed until they see us, and it might be a while before they get into a good heart failure clinic. But even if they do, we can be doing proactive treatments. We know that the recent trials have shown the benefit of the SGLT2 in reducing risk of hospitalization. And then we've got the certainly outstanding data in terms of renal disease. And perhaps one of the most exciting things from this summer is the role of these drugs in reducing cardiovascular and renal disease in patients who don't even have type 2 diabetes. So I think that kind of ends my section, Alex.
Thanks, Stuart. What a great presentation. I think we obviously all value your expertise. Harpreet Bajaj couldn't make it this evening because he's a busy guy with obviously the new guidance coming out. I swear he did not tell me that they were coming out today or yesterday. That was totally by accident that we included that in the DC guidelines in case I'm going to get in trouble when he watches this recording later on. So a little bit out of order again. Again, you know, in the interest of time, we did start a few minutes late. Anybody who has any questions for Stuart or Rob or Eileen, please use the chat. We already had one question come in, which again, we'll save for the end, but I assure you I'm collecting all of the questions for a brief panel that we'll have. Now we'll go back to our first section. So thank you, Stuart. I'm gonna take away the screen share. Just a sec. Eileen, if you are able to take control. Yeah, good, we hear you now.
Good,
so
thank
let's
you.
see if you, so welcome, of
Thank
course.
you so much. I'm sorry about
No, it happens. The technical glitches of Zoom, as we all might guess, during a pandemic, it happens. We're so happy that we can see and hear you. Would you like to try sharing your screen? As mentioned, if there's any issues, I'll advance the slides. While you're trying to do that, I'll introduce you to our group. Eileen O'Meara, and I hope I'm saying that correctly, is the cardiologist and associate professor of medicine at the Montreal Heart Institute, or l'Institut de Montréal, as it's better known as. She is in the Department of Medicine as well for the, at Université de Montréal. In 2010, she became a member of the Internal Review Board of Research at the Montreal Heart Institute, and in 2014, she became the director of the institution's anticoagulation clinic. She also received her MD from the University of Montreal in 2003, and later pursued a fellowship in heart failure at the Glasgow Royal Infirmary in the UK, and another in stress echocardiography in Paris. It's obviously our great pleasure to have such an expert in the field, and I didn't invite her only because she's from my hometown, Dr. O'Meara. I'll see that because you haven't shared the screen, why don't I do that for you? All you'll have to do is tell me when to advance the slides.
All right, thank you, Alex, and sorry for the glitches, and thank you, Robert and Stuart. Actually, that was very interesting because it's a different perspective, and I think it might actually fit better that way, because now you have all the data and you can understand where that fits for us in heart failure. So next slide, please. And here are my disclosures. I guess as these are recorded, we don't have to look at them too long. So this is Robert. He's a 74-year-old man with type 2 diabetes for 24 years. He has hypertension and dyslipidemia for 30 years. He's on metformin, sitagliptin, 1,500 daily, insulin glargine, 330 HS, telmisartan 80 daily, amlodipine 5 daily, and atorvastatin 20 daily. So if you see that, you think he doesn't have heart failure. Now he tells you about his symptoms: dyspnea on exertion, NYHE 2 to 3, fatigue, ankle edema, orthopnea, and you do the physical exam, because I'm sure endocrinologists do that, and the JVP is elevated. He's got an apical holosystolic murmur, and you hear rails at the lung bases. Next slide, please. Okay. So labs and patient discussion is A1C is at 6.8%, LDL cholesterol 1.8, eGFR 52, ACR 6 milligrams per millimole, BP is 128/68, and his heart rate is 82, BMI 31. He complains about feeling low, sluggish, doesn't feel depressed but tired. His wife says that he's been sleeping with one more pillow, and his breathing is altered while he sleeps. He feels that maybe it's just him getting older. Next slide, please. So what would you do? Now you've been practicing that. Order an echo and or NP levels, BNP or NT-proBNP. Refer to a cardiologist. We heard that it might take some time depending where you're located and if you're in a pandemic. Add an SGLT2 inhibitor. Add an SGLT2 inhibitor and decrease insulin. Add an SGLT2 inhibitor and discontinue DPP4 inhibitor. Add a GLP-1 receptor agonist and discontinue the DPP4. Nothing. Follow up as patient is in a reasonable glycemic target zone.
So we've certainly upped the challenging nature of these questions. We obviously want you to respond as you, of course, might do so in your regular practice. I'm certain this question would be answered very differently if we were presenting this to a group of cardiologists or even family physicians. But tonight we hear from the endocrinologist. There's still a tiny bit of movement, so let's give people another, maybe 5 seconds. If there's those, pondering over that big juicy steak, what you might choose. No, okay, so fantastic. Let's broadcast the results. Eileen, what are you thinking? A group of endocrinologists, sort of in keeping with what you would have guessed, or maybe a bit surprised?
Well, I'm happy, and Stuart did some good teaching there from what I heard. Echo and or NP levels, depending on how easy you'll get each one of these. And possibly you would want both in this case, since you have serious suspicions for heart failure. You actually know that he has heart failure based on the signs and symptoms. You just don't know the EF, so you don't know exactly how to treat the patient best. And the NP levels will tell you more convincingly that the patient has heart failure and how euvolemic or not he or she is, and give you a base point to start with for your treatments. SGLT2 inhibitors, that's very interesting because we're gonna have to place them in the heart failure algorithm, as you'll see later for the next outline of our guidelines in heart failure, but we can move on for now. Alex, you want to comment on that, or Stuart or Robert?
I was a bit surprised. I don't order a lot of echocardiograms routinely. I'd probably have been more in that refer category. But, along the lines of maybe if BNPs were a little bit easier to access, as I think there's a charge in Ontario, might at least help with the barrier. I'm not sure. I'll open it up to either both Stuart and Rob if they do something differently, and everybody else would like to either speak or answer what they would do in the chat.
Yeah, maybe we can go on with that discussion after, because it's maybe go back one slide, Alex, because it's very interesting, and it will also depend on your LVEF and on what the guidelines will recommend, although the guidelines, as you all know, are not the payers. So that's two different entities which sometimes work together. So the echo shows an LVEF of 35%, and probably, as you heard the murmur at the apex, it would show MR of at least 2, maybe more, mitral regurgitation. You would want to have more information, but that's the main one for now, because you want to know in which group of heart failure the patient was in, and we're going to come back to that. The BNP here should have been erased because it does not correspond to the NT-proBNP of 2500, which we use more often now that we use Entresto, because in the beginning of use of Entresto, you'll have a false value of BNP, which is caused by the treatment itself. So you'll have more reliability on NT-proBNP. If you were to But the way I saw this patient, he would have at least an NT-proBNP of 2500 based on the signs and symptoms and having low EF. Next slide, please. The normal for, if you wanted to participate in a trial of heart failure with reduced EF without atrial fibrillation, now you would need at least 600 of NT-proBNP and 1000 if you had atrial fibrillation. So heart failure is a highly prevalent condition. As you know, this is the slide that everybody's been showing for the probably past 5 to 10 years. So at least 26 million adults are living with heart failure, and that's nearly 700,000 Canadians. As many as 1 in 5 adults 40 years of age will develop heart failure during their lifetime. So apparently we won't be retiring too early. Next slide, please. Obviously, heart failure is associated with poor outcomes, and the data presented here is still quite true. At 1 year, the total mortality rate for a patient hospitalized for heart failure is 17%. Well, that depends how the patient was treated prior to having this hospitalization, and might have changed a bit at this point. Approximately 50% of people with heart failure will die within 5 years of a new diagnosis of heart failure. And at 1 year, the readmission rate for patients hospitalized for heart failure is about 44%, which is extremely high. The cost of healthcare and for the patients as well, of course. Next slide, please. Can you hear me? Okay, sorry. 2 main types of heart failure, and in that we could probably the reduced AF side. So HFpEF, or heart failure produced AF, which was previously called diastolic heart failure. We don't use the term anymore because it's a constellation of many different abnormalities in the heart, despite an ejection fraction of 50% or more. If you're going to say HFpEF, mid-range AF is from 41 to 49, and 40 or below is classified in the guidelines as HFrEF. So the typical HFpEF will have concentric hypertrophy, especially if it's due to hypertension. Stiffened and thickened walls. You need to have, in the current studies for HFpEF, at least one criteria for LV hypertrophy and one criterion for left atrial dilatation. You'll have abnormalities of filling and relaxation associated with multiple non-cardiovascular comorbidities, including diabetes. There's also some degree of valvular disease, but if you have moderate to severe valvular disease, that is primary, and that's going to be termed heart failure caused by valvular disease and not HFpEF. For HFrEF, you have, in the vast majority of patients, except eccentric remodeling with EF 40% or less, stretched walls and dilated chambers in the progressive stage, not necessarily at the beginning. Failure of normal contraction, so systolic dysfunction. Previous MI is the most common cause. As we'll see, 50 to 60% of HFrEF is due to an ischemic cause. Next slide, please. Dyspnea and edema are typical symptoms. As you know, in low cardiac output, you'll have impaired thinking. Orthopnea and paroxysmal and nocturnal dyspnea can be symptoms. Increased heart rate, fatigue, exercise intolerance. On the physical exam, elevated jugular venous pressure, coughing, wheezing, decreased appetite, and fluid buildup at the ankles. So shortness of breath, of course, is the main first presentation symptom, but if you only have a dominant right heart failure, you might see only jugular vein distension and peripheral edema. And of course, that won't tell you whether ejection fraction is preserved or reduced, although you can have an S3 in reduced, and you can have more MR in reduced, but that won't tell you the exact prototype or phenotype, and then that will not help you for treatment. As for now, for HFpEF, very few treatments that change the outcomes. On reducing heart failure hospitalizations with aldactone and with candesartan, and if you had not included Russia and Georgia, aldactone would also have reduced mortality in HFpEF in TOPCAT. Next slide, please. Heart failure is recognized as a complication of type 2 diabetes. So this distribution of the initial presentation of CV disease in patients with type 2 diabetes. So they have heart failure in this set of data in about 14% of patients, but as you can see, they have many risk factors for heart failure. Diabetes is a strong risk factor for the development of HFpEF, but also for HFrEF, since there's a lot of cardiovascular disease. Next slide, please. Hyperglycemia and obesity can induce cardiac remodeling. Hyperglycemia, insulin resistance, obesity, I'm sure you're very familiar with that. Inflammatory cytokine release from adipose tissue, increased oxidative stress, mitochondrial dysfunction, altered substrate utilization, free fatty acids used instead of glucose. And then the patient will develop cardiac fibrosis that may reduce myocardial compliance, LV hypertrophy, and then this would cause typically HFpEF, but as you know, they can easily develop HFrEF with frequent incidence of myocardial infarctions. Next slide, please. So strong relationship between diabetes and heart failure. This is the age-associated prevalence of heart failure in individuals with or without diabetes. In red, you have those with diabetes, and in blue, without diabetes. You can see that's much more frequent in those with diabetes. And on the right, you have the stats here. 10 to 30% of patients with type, if you can go back, please, with type 2 diabetes also have heart failure. As you know, Stuart presented data here that's more recent, and it shows in heart failure, patients will have 30 to 40% diabetes, but that's the reverse, and we'll come back to that. And you have this below 30% with heart failure, type 2 diabetes, and when we select patients with real signs and symptoms of heart failure, you get to 40 to 50%. And that's from EMPEROR and DAPA, the most recent studies. Next slide, please. That's also a bit discouraging. I'm hoping that this has changed. So the proportion of patients surviving with diabetes without heart failure, that's encouraging. But diabetes with incident heart failure, now that could still be partly true because this is an incident heart failure. But survival of less than 20% at 5 years might be a bit severe here with all the treatments that we have now. And that I think is dated 2004, and spironolactone in heart failure was started in 2003, and you can imagine all that evolved since then. So I'm hoping that this statistic has changed. But still, patients with diabetes and heart failure have a 5-year survival rate of 12%, which may be true for HFrEF. And patients with diabetes but without heart failure have a bit. Next slide, please. Okay, so that's interesting. So heart failure prognosis is worse in patients with diabetes compared to those without diabetes. In red here, you have patients with diabetes. The full line is HFrEF, and the dotted line is HFpEF. And incidence of CV death or hospitalization due to heart failure. And in blue, you have without diabetes, HFrEF in the full line, and HFpEF in the blue line. So you see that HFpEF always does better in each group in terms of prognosis, although it is not that good either. But it's interesting to see that diabetes really changes prognosis dramatically. Next slide, please. So that's the algorithm that we published in 2017 for what to do when you suspect heart failure, like for this patient, Robert. So you have on the clinical history symptoms, functional limitation, risk factors, exacerbating factors, comorbidities, drugs. Physical examination strongly suggests heart failure. So then you'll do the clinical investigation. Start with an X-ray, an ECG, blood work, CBC, lights, renal function, urine analysis, glucose, thyroid function. You still suspect heart failure? Yes. Then you do the NP levels, NT-proBNP more than 125. So you see they've been very sensitive here, and that's based only on one set of data. If you want to catch heart failure early, you might want to use that cutoff. You might do a lot of echoes. You could use 300, but you can go to the echo. It is very much advised if you have a patient like Robert, and then it will tell you in which group your patient is. And then you will have additional diagnostic testing in that case, probably search for ischemia. Next slide, please. And here's the etiology algorithm that we published. So at first you have those first test, echo, ECG, chest X-ray labs, ferritin is amongst them. Divide HFrEF in the same branch as heart failure with mid-range EF, as I said earlier, and HFpEF, but the common etiologies are the same for both groups, with ischemic heart disease as a primary cause in 50 to 60%, as I said, for HFrEF, and hypertrophy or hypertensive heart disease, the second cause even in HFrEF, but the first cause in HFpEF. And then for all heart failure, valve disease and tachycardia induced, you can see a patient with atrial fibrillation come in with heart failure lots of times. You might not find much abnormalities on the echo, although a lot of these will have a history. Hypertension might have marks on that on the echo. And then you go on with all the specific etiologies, and diabetes is a metabolic disorder, which in itself sometimes can be associated with heart failure without any other abnormalities, just by diastolic dysfunction, which was previously thought, but there might be other interesting metabolic causes that are addressed by the SGLT2 inhibitors. Next slide, please. And here's what we do when we have a patient with HFrEF in our heart failure clinics, and that's the algorithm that should be followed. This was published in 2017. We are currently working on revising. I'm no longer the co-chair, but I'm still working on that. I saw the proposed algorithm. We don't know what the final one is going to look like, but that's a very interesting questions, and you guys speaking before made it even more interesting. So all patients with an EF of 40% or less and symptoms of heart failure should have triple therapy, which is ACE inhibitors or ARBs. We still start with the ACE inhibitors also, although that's not really true in practice, but that's the history of the trials, beta blockers and MRAs. And this is dated, like I said, since 2003. So all patients should be at least on that. You saw that Robert was not yet on that. And you increase the doses every 2 weeks. And then you reassess symptoms once they're at max tolerated dose or target dose. If they're in YHA class 1, so no longer short of breath on exercise, continue triple therapy. If they're in class 2 to 4, sinus rhythm or heart rate of 70 or more, you can add ivabradine based on the SHIFT trial with a heart rate of 70 or more, which will lower the heart rate purely, and also switch the ACE or the ARB to the ARNI, which is Entresto, and that's already been published 6 years ago, but it went into practice about 2 years after. And NYHA 2 to 4, sinus rhythm with a heart rate below 70, or with AFib or a pacemaker, and you just switch to ARNI because the ivabradine won't add much benefit, and it will add nothing at all in a patient with atrial fibrillation. And you should do all that, optimize these last steps, ivabradine and Entresto, within 6 months and as fast as you can, which is not the easy part, which is why if you guys in endocrinology and everybody else contributes, then that's ideal for our patients. Then you reassess symptoms and LVEF. NYHE or LVEF above 35, you continue the management. If you have NYHE 1 to 3, and LVEF 35 or less, consider cardiac resynchronization therapy and ICD. And there's an algorithm for that, but we won't go into details. NYHE 4, then you consider referral to an advanced heart failure team to consider mechanical support and other advances therapy that we don't need to go into details here. And I'm sure you have patients with CKD who've been on hydralazine nitrates, and old recipe will have stronger drugs probably for them, hopefully prognostically better than these. And you can consider palliative care in some instances. Next slide, please. So meet Evelyn. Evelyn has a cardiologist who knows about heart failure. She also has a good endocrinologist. See, she's 78, type 2 diabetes for 10 years, HFrEF for 8 years, NYHE class 2, LVEF 30%, that was 2 years ago. She's on metformin, linagliptin, rosuvastatin, ramipril, hydrochlorothiazide 5 and 12.5 daily. In heart failure, it should ideally be BID if you're going to take ramipril, but the hydrochlorothiazide you won't give at night. Eplerenone 25 daily, so the cousin of aldactone or spironolactone, and she was probably intolerant. Otherwise, it would not have been covered. Although in cardiology, we tend to think eplerenone has some better benefits, but this was never recognized by the payers. So it will be spironolactone unless she had intolerance. Bisoprolol 5 daily. So she has the main triple therapy. There could be improvements in that. Next slide, please. Her A1C is 7.2%, LDL cholesterol 2.1, eGFR 65, ACR 4, BP is 132/74, heart rate 68, BMI 28. She now has significant edema in both legs. She complains of fatigue. She feels weak and has a low appetite. Next slide, please. What would you do for Evelyn now? Order an echo and or NP levels, refer to cardiology, add an SGLT2 inhibitor, add the SGLT2 inhibitor and discontinue the DPP4 inhibitor, add a GLP-1 receptor agonist and discontinue DPP4, add furosemide, nothing, follow-up routine as patient is in a reasonable glycemic target.
Definitely have like a flashback from medical school, looking at the JVP, maybe pretending that I was seeing it and maybe probably wasn't seeing it. And, you know, the complexity of a lot of heart failure management, I think, is echoed today, and sad truth of some of the prognostic factors. As I speak, we still see some movements of the line. So we'll give everybody again, maybe another 5-10 seconds. A lot more of the distribution here than probably we were expecting. Okay, so we'll end the poll right there, and we'll of course share the results. Eileen, this time, you know, I think, I guess we're ordering less tests for this patient. Maybe we already know a little bit about how she's doing, and in this case, moving right to the SGLT2 inhibitor and discontinuing the DPP4. Thoughts?
In terms of heart failure, we'd still do an echo because our symptoms and signs have changed, and maybe you also need to know if the EF is above 40. So if you can switch to Entresto, if you want it to be covered, you have to know that because it has to be 40% or less. NT-proBNP will always give you prognostic impressions that are important for patients like that with an LVEF of 30%. And I'm glad that some still want to refer to cardiology, although that might be long. I think that might be important for her too. And yes, if you want to add the SGLT2 inhibitor and discontinue the DPP4, I would definitely be in favor of that. And then we'll see how the algorithm works for the next one that'll be presented maybe in the next few months, maybe next month if we're lucky. In Canada, that is. Add furosemide, you would need to do that too in that case, because she was not euvolemic, and every time patients are not euvolemic, you'll have trouble increasing their heart failure therapy. That is going to change outcome. So this is what we've come now to in the past 15 years. It's quite impressive, and now we have 6 medications and 2 devices that reduce total mortality in heart failure. It was not easy to reduce mortality in heart failure before the year 2000. ACE and ARBs, you have NNT for mortality at 1 year and then at 5 years. So you can see, and then beta blockers, 40, amazing. MRA, 75. Ivabradine for the SHIFT trial, if you have a heart rate of 77 or more, because then there was a benefit on mortality. Above 70, it was a benefit on heart failure hospitalizations being reduced. The ARNI, sacubitril, valsartan, or Entresto versus ACE net benefit. And then DAPA, and that was before, that slide was made before the publication of EMPEROR-HF. But in EMPEROR, as you might know, cardiovascular mortality was not reduced in just 16 months of follow-up. And there's a lot of debates on why these differences between the 2 trials, but I don't think we'll go into that. So still, the estimated NNT here at 5 years would be 16 for DAPA, and 1 year 67. And devices, you see that they have a very good result as well. So this step is also important, and we cannot let it go. And now we have EMPEROR-Reduced and DAPA that are published. Victoria should have been on the left because it's been published in the spring, and it did meet its primary outcome. Vericiguat is a soluble guanylate cyclase stimulator, vasodilator with a lot of interesting pleiotropic properties. And it was in patients very with advanced heart failure, and this will be included in the next algorithm. The question is, where will it be included? And DAPA CKD, as you know, has been presented, but to my knowledge, not published. It would have been on the left as well. EMPEROR Preserved is still ongoing, as well as DELIVER, which is dependent with dapagliflozin with Preserved DF, which I'm involved in, and Galactic HF, omecamtiv mecarbil versus placebo in HFrEF. That's a myotrope, so it will increase the actin-myosin link with increased systolic function without increasing intracellular calcium. So very promising. We just closed the trial. Actually, the database will be closed at the end of the month, and I'm hoping the results will be available in November. And I'm involved in that very much as well. So looking forward to see even more in that algorithm. So yes, I think DAPA is important. The current discussions are, where should it come now? We don't have data in acute heart failure in hospitalized patients. So should we really wait until we've put the triple therapy on board? So interesting to see your perspective on that as well.
I think that's about a
I
great
think that's our last.
segue. Yeah, that's right. Thank you so much, Eileen. I think that really, take us through, I think, the evolution of heart failure, I guess, in the last 16, 17 years. Obviously, some impressive results. I think that, that's a great place to pause, at least to outline the next steps. If anybody has any questions for any of the members of the panel, thank you, obviously, Zaina, for asking about the TIMI score in this real-life case, which, as everybody could see, I think Dr. Schlosser already answered. If there's any other questions about where you see this fitting in the management of your patients, I think Eileen's last point of, should they be on triple therapy? Should we be using this earlier? I'll pause there, and if anybody has any questions, we'll obviously take you through that question slide before, of course, we, sorry about that. Yeah, so any questions at all? And before we conclude the evening, I'll take us through maybe 2 minutes of next steps, at least for the program. Well, I guess people are typing in. Why don't I ask the first question? As you know, it often comes up, at least with SGLT2 inhibitors. And whenever I speak to cardiologists, they tend to be most impressed with at least the preventative nature of the ability for these drugs to prevent heart failure. We're focused a lot on treating heart failure, preventing heart failure, at least in those without established disease, maybe more of a nuanced field. How do you look at it, Eileen? Do you view these as, you know, the advanced failure when I'm going to be thinking of aldactone, or maybe along the lines of prevention earlier on, like an ACE inhibitor, or maybe both? Maybe, you know, there is no patient that isn't necessarily, it's too late to be using it.
I think it's very important to prevent heart failure, and definitely have a group of patients there with diabetes that are extreme risk of heart failure compared to the other populations. And then especially those who have other comorbid conditions associated with heart failure. So you do have a great opportunity, and then we won't have to ask ourselves where to add it in our algorithm. It'll be more complicated for us, for those who don't have diabetes, because for those who do, we think it should be, most of us think it should be, and I'm talking about the heart failure group here in Canada, but I think anyone who has seen the data would agree that in patients with diabetes that have remotely sign of heart failure symptoms or elevated NP levels should be started on this SGLT2 inhibitor. Definitely more than a DPP4 inhibitor, that's for sure. And then there's always the question of between GLP-1 receptor agonists for those who have a lot of vascular disease in comparison to more risk of heart failure, which is not easy to tell, I guess, in what we call primary prevention or prevention of heart failure.
No, thank you for that. I'll open it up to the group, including Stuart and Rob. Heart failure was mentioned in today's guidelines that Harpreet was nice enough to share with us. Did they get it right? Did you agree with the way the perspective of the committee took some of the outcome benefit, still focusing on glycemia? Obviously, we can start with Rob and Stuart, and you know, anybody else on the line. We obviously like to see you if you want to show your face, but you can also chat or speak to it as well.
So while we're waiting for questions, I guess I'll put in my view. I must admit that if as a host, we didn't get a chance to answer. For the patients with advanced heart failure, you know, there's so many new therapies that I would, and we have good access to a cardiologist where we work, so I would refer to a cardiologist. We deal as endocrinologists more in prevention of heart failure, and similarly in hopefully prevention of kidney disease before it happens. And I think that's the strong suit of the SGLT2 inhibitors. Even if we're not doing an echo or know the status of the patient's BNP, for a large swath of patients, many of whom would have qualified for one of the trials that we talked about, an SGLT2 inhibitor would be beneficial on many levels, metabolically, their weight, and then as a side benefit, even if they have nothing, their long-term risk of heart failure and likely kidney disease is reduced. So I agree with what Dr. Mira said, is that clearly the SGLT2 inhibitor should be thought of early in the course. You can argue before metformin or with metformin. I would suggest if they have diabetes, should be with metformin. But regardless, I don't think A1C necessarily should be the trigger for many, not all, I can't generalize perfect, but many patients. A1C doesn't necessarily need to be the trigger for starting the patient on an SGLT2 inhibitor because of all these benefits. You know, I'm stricken by the fact there's now 8 outcome trials with SGLT2 inhibitors, and 8 out of 8, including some that didn't have a primary outcome that was positive, but 8 out of 8 of these trials show significant heart failure benefit, ranging from patients at very low risk to patients with clear-cut HFrEF. So there's a clear benefit along the whole spectrum of heart failure for this drug, along with many other benefits. I don't think we can argue with the fact that this class, you know, we can argue which drug has the best evidence for which patient, but we can't argue that the best evidence for heart failure, both prevention, primary prevention, and secondary prevention lies with the SGLT2 inhibitors.
I would certainly agree with that. I think a whole concept of us in endocrinology should be one of prevention. We have a chance now to actually prevent what are really lethal complexities. As Eileen mentioned, the prevalence rate of heart failure amongst our diabetic patients is high. By the time we detect it or they present the symptoms, I think they're well on the path to difficulties. Same with renal disease. At least now we monitor more carefully, and our family doctor colleagues are watching also very closely. But here's the interesting question that has always been in my mind about the way we treat. I've always felt that when we treat diabetes, even before we had the SGLT2 data, is that at the very beginning, we should be far more aggressive, and that the use of multiple drug therapies at the very beginning alters the course of the disease. And there's pretty good evidence out there that that's exactly the case. So now you have a situation, if you're really keen on metformin, I was rather intrigued in the guidelines. They talked about the low side effect profile of metformin. I wonder if you've asked your patients, do you have any problems with your bowels? Because about 30% of them will tell you yes, and some of them can't even leave home for any length of time because of it. So it's not a benign drug, and now we're getting drugs which will actually allow us to keep that dose of metformin low or eliminate it, and prevent the potential of prevention. And we've got the trials. We don't have to guess it. As far back as Canvas and DECLARE, the information was there that you didn't have to have heart failure to get prevention of the risk of heart failure. So I think, to me, this is the big change which is about to occur. I think there will be the intent of multiple drug therapies. I think that we'll be using drugs when there are not specific symptoms of heart failure or renal disease, because we know that we can actually do something about it. And we have the evidence to prove that. I think this is going to take a lot of reshifting in terms of many of us who have done it the old way for a long time and feel that it is proven. I think we need to be rethinking a lot of the way we approach clinical management.
Let's open it up again if anybody would like to ask or type in a question.
Actually, I had an interesting question in private asking about the accessibility to NP levels. And in Quebec, we've worked a lot to make it non-restricted. Now the people who do the blood work don't know if you're a cardiologist or not, and they will do it even at the CLSCs, so outpatient setting and everything. So Ontario, I'm pretty sure that access is easy. I know it's not that easy in BC, so I don't know if my colleagues want to comment here on that.
It's certainly freely available in Alberta. Anybody can order it.
There's a $30 or $40 charge, I believe. Rob, you'll correct me if I'm wrong, for BNP in Ontario.
Something like that.
Yeah.
It's $20 in Quebec. You guys are expensive.
The cost of living in Toronto, that's how it works, yeah. Somebody had actually typed a question. I think this was meant for everybody, but it came to me. And it actually segues very nicely, at least to the next steps that I'll outline. I think the question focuses on that well-controlled patient, and if they don't necessarily have an echocardiogram, what makes you think of heart failure or outcome prevention if they don't necessarily have it? They mentioned age, question mark, inclusion criteria for the trials. I guess, you know, the question here is, if we're thinking clinically, we seem all convinced that if you see a reduced ejection fraction, doesn't happen to be on an SGLT2 inhibitor, seems like a slam dunk. But a lot of those patients with preserved ejection fraction at risk for heart failure, they don't have echoes. They may not be as obvious. Anything that, you know, potentially triggers. We'll start with Eileen, and we can hear from the others after.
So you mean a diabetic patient that would have an A1C of 7% or less? Is that the question?
That's right.
Okay. So to suspect heart failure or a risk of heart failure that's higher than in other patients, you would see a patient with hypertension, a patient with vascular disease, either cardiac or peripheral. They're at risk of developing heart failure, definitely. You know, all the typical cardiovascular risk factors, obesity, and that's a lot of your patients with diabetes. So, you know, hypertension, obesity, diabetes, smoking, age, etc. You know, the classical cardiovascular disease factors. I don't know if my colleagues want to comment.
No, I agree. Obviously, I mean, I presented it for the TIMI risk score is a fairly easy way. I think it's underused, but it's very valid, very simple, and maybe a good project would be to develop a simple macro or a screening tool within our EMRs to give the TIMI risk score. If it's 2 or 3 or higher, then you have, yes, you can do all the tests, but those patients clearly, if they're not on an SGLT2 inhibitor, you have to ask yourself why, because they're, from a heart failure point of view, you already have a large risk based on a validated risk score.
Any other thoughts from the group as well?
There's a score also that's it's called HF2PEF. I didn't present it, but that's for to have a high suspicion of HFpEF actually. So it's basically very similar to what I just said in terms and what you guys just said also to me. But the HF2PEF is interesting as well.
Thank you. A great segue, at least, to let's go to the next steps of the program. And sorry, I'm backing up here. Great. So just like last time, a Realize Reflect program involves, of course, the completion of tonight's program. For those attending live, we obviously thank you for your attendance. Those who are obviously watching online, you'll also have an opportunity to complete an evaluation. Varja is now going to add the link to the evaluation so that you can just click on it directly. You'll also see it on the last slide, which I'll just leave up as people file out. Then over the next 3 months, we'll obviously talk to you guys about what that ideal patient is. I think Rob has put it very, very well. We're exploring, obviously, utilizing the TIMI risk score, whether that's something we can create as a macro, whether that's something that we can query and make available to you, showing either patients on or not on SGLT2 inhibitors. With DAPA CKD, not quite presenting, but showing some more recent data. There's, of course, maybe some renal things that we can look at, which we'll share with you. A lot of that will be captured on the program evaluation. And then, as always, there's that final follow-up survey. We're hoping for sometime in December so we can wrap up the program before the end of the year. And as I did promise you for the other 2 programs, there is a share back of all of these results. For the 2 programs we did earlier this year, one is coming at the end of the year because it takes a little longer to collect the data, and one that happened in January will be shared with everybody shortly. So as always, we like to show the impact of the program. As part of the program, is we make it completely optional to participate in the next step. Whatever we decide on being that ideal patient based on the feedback that some of you have put in the chat, as well as for some that will be completing the evaluation, it comes down to the choice of either getting an EMR prompt, a list of all the identified patients. There may be 1 or more patient profiles, or neither, and you just apply the learning, obviously, to your own practice that you learned this evening. There's no obligation. Here's a preview of at least some of the evaluation form questions. I think we touched on these really by accident and out of order. The idea of whether we should be using a heart failure, potentially another risk stratification tool, really considering the benefits here for HFrEF or HFpEF or both, again, based on that DECLARE sub-analysis that we saw, as well as EMPEROR-Reduced, but not EMPEROR-Preserved having published yet. And as we always talk about when it comes to the SGLT2 inhibitors, since the data tend to be fairly consistent as presented by Stuart, with some nuances, at least in the statistical power of the conclusions, how you view the class as being either a class or agent specific. Obviously for those interested, we do have not another Realize, Reflect, React, but this is our next CME program for our group. We'll be talking about fixed ratio combinations. You should have all received printed invites, and of course the Zoom link is also available. Varsha will also share this Zoom link with everybody so that if you'd like, you can register, or of course register later, as it's still a few weeks away. So I think that's the last slide for the evening. We obviously thank everybody for being in attendance. I'd like to thank Stuart and Rob and Eileen. If you'd each like, we can give you, the final thought before we conclude. Eileen, why don't we start with you?
I think there's immense work to do between us to make these treatments that have been started for diabetes and now that can even provide benefits in non-diabetic patients, to get them to the patients as soon as possible to prevent progression of their disease.
Rob?
I agree with everything that's been said, and it's really exciting that we now have treatments that are so based in excellent evidence-based trials that we can really hang our hat on and say, look, especially when we're trying to convince patients, because as we all know, patients can be on 8 to 10 plus therapies, and adding another one elicits a lot of pushback. A lot of the therapies they're on have really poor evidence or scanty evidence for benefit, so we may be replacing one with another, but at least we have some ammunition to say, look, these drugs really can make a large difference in things we want to prevent or treat, and that's very exciting.
And Stuart, as always, you get the final thoughts.
I think it's a time of change, and I think it is, Rob said, it's exciting. I think we're going to have to rethink a lot of the way we approach our patients. We're going to use modern technologies like EMR reviews in our systems to alert us. But I think we'll be looking at very different medications over the next years, which will not only be for treatment, but also for prevention. And I think that's a wonderful status to be in modern diabetes.
Couldn't have said it better myself. Thanks everybody for obviously being here this evening.